Welcome to Healthcare du Jour, where we dish up and digest the latest in healthcare. For the next 30 minutes, sit back as we bring you insight, commentary, and discussion on trending topics to the table, all expertly served up by our host and his guests. Now here's your host, Matt Fisher.
Welcome back, and thank you for joining as we dive into the hottest topics in healthcare. I'm your host, Matt Fisher. On the menu today is Ed Hoffman, SVP of National Transportation and Mobility Operations and Strategy at Modivcare. Ed, welcome to the show.
Hi, Matt. Thanks for having me.
So, Ed, what I always like to do at the beginning of every episode is to give my guests a chance to provide more of an introduction in terms of who they are and what they do. So, Ed, the floor is yours.
So I am the Senior Vice President of Transportation Mobility at Modivcare. I have a broad responsibility, but it's really focused on getting members, our Medicaid and Medicare members, to and from their medical appointments on time, safely, and in a regulatory and contractually compliant way. Many of our members are part of fragile or disadvantaged communities, Medicare and Medicaid, and our responsibility is making sure they have the access to care that they need. So, in addition to that responsibility and service delivery, it's also managing and maintaining the partnerships that we have with the different mobility solutions in our network.
Yeah, no, I think a lot to be able to pull apart there because it's, I feel like when most people think of transportation and healthcare, the only thing that comes to mind is an ambulance and not kind of those fine details on day-to-day kind of needs. But before we start pulling all that apart, the other question I always like to ask is, what got you into healthcare in the first place?
So I actually came in largely through technology. This was a while ago, back in about 2008. Lots had moved to the cloud in terms of how you manage networks, and we were working on bringing transportation scheduling, management, and payment into the cloud. And that actually brought me into non-emergency medical transportation. The software that we were building, the services that we were connecting, the networks that were being built were an ideal fit to serve the communities that NEMT serves. And that brought me to Modivcare. I came into Modivcare in 2016 to help develop a more technology, digitally advanced network solution because so much had changed with rideshare in recent history. And we were sort of embarking on what I would say is a new era of transportation. And that's largely how I came into this space.
It sounds like a really interesting journey, and it's kind of the baseline is kind of applies in so many different parts of healthcare. But I would like to see if we can start really teasing apart the details of what you were initially describing. And you just referenced non-emergency medical transportation, or NEMT, as it sounded like you shortened it to.
Yes.
So if you don't mind, can you explain what exactly does that cover?
Non-emergency medical transportation is designed to help its members and beneficiaries get to more routine medical services and appointments. You had mentioned ambulance services, which generally serve emergency transport, but these are for routine doctor's visits as well as social care. So that would include dialysis treatment, substance abuse treatment, mental health treatment, pharmacy stops, specialty visits, as well as prenatal care. So these are things that sit outside of emergency transportation, but are critical to the well-being and health of the communities.
And what are the types of services that help with those transportations? Could it be in an ambulance, or I know you just referenced ride shares. So does that play a factor into it as well?
So part of our responsibility at Modivcare is actually making sure that the member gets the level of service that they require, and that can vary greatly. In some instances, you have people that are in very good health. They simply lack transportation or mobility in their personal life. And on the other end of the spectrum, you have people with significant chronic health issues. Perhaps the nature of the treatment itself doesn't allow for driving yourself responsibly. Dialysis would be a perfect example of that. And so our members and the communities we serve have a wide range of needs, and we develop sort of a full spectrum of solutions that helps them meet their needs. That could be allowing them to have mileage reimbursement. Perhaps there's somebody in their life that can transport them and we reimburse them for mileage. That could be public transit for members that live within a quarter mile of transit stops that allow them really on their own schedule to move from point A to point B. It could include people that are quite well, and we could leverage rideshare. And then you start to get into communities where you have treatments or conditions or physical limitations that require higher levels of service, wheelchair, stretcher, et cetera. And we sort of build out this full spectrum of mobility solution and make sure that we are matching the member with the exact level of service that they need for their requirements.
And when you're identifying the members that need the assistance with the transportation, is the member reaching out to you, or is the clinician or other service that they're going to reaching out, or is it some combination?
It's all of the above. So we will have the members obviously themselves will reach out and schedule transportation. It is not unusual at all to have a caregiver or family member involved in the scheduling. So they will reach out to Modivcare and schedule on behalf of the beneficiary. And then we work very closely with healthcare providers and facilities such as dialysis centers, substance abuse centers, as well as discharge planning within health systems and hospitals. And we provide all of this is supported by technology. So no matter who the person is that's doing the scheduling, who's receiving the service, we have a technology solution, whether it's a live agent or an app or a scheduling portal to help make the scheduling of that transportation and tracking that service very simple.
So, I know you've kind of talked about the technology piece of it, and you're just starting to get into some of what that covers. So is the technology that is in place unique for the NEMT, or is it something that kind of layers into and interacts with other technology systems that other parts of the industry might be utilizing?
So it does both. So in our industry, there are unique requirements. So we're often having to follow a benefit plan design by the payer sponsors, whether that's a state Medicaid agency or a managed care organization or Medicare Advantage. So there are requirements and qualifications, including ensuring medical necessity, ensuring that we have the proper paperwork, ensuring that we're associating the ride with the correct level of service. So behind the scenes or underneath the surface, there's a lot of technology to make sure that we're doing all of that correctly. For what touches the market, it's designed to be very simple. It's designed to kind of feel like Expedia or Uber. We try to take all of that friction and complexity out and keep it very familiar for the user.
Yeah, and that certainly makes sense because it's, I think as you're suggesting, it's, like having that strong user interface that mirrors or mimics what you might get in other places kind of helps drive improved utilization and, willingness to engage with the information that's being presented.
Exactly. And we're in a highly regulated industry. So making sure that we are doing things correctly and appropriately, complying with regulations and requirements. And then there's the other aspect of this is you're sort of dealing with an ecosystem, meaning the relationship between the caregiver and the member, the healthcare provider, and the health plan. There's this interdependency and impact that exists between all of those stakeholders. And our technology is designed to kind of create visibility and communication and transparency sort of in that community. So everybody's in the loop and everybody's up to speed with the latest and most important information.
Yeah, so if you're talking about, as you just said, a number of interdependent players, what are some of the challenges of ensuring that you're connecting with each of those different constituencies? Because, I suspect, kind of implicit in what you're saying, each of them has different needs and they're all going to be coming at the issue from a slightly different perspective.
Of course. So there's sort of global or universal interest in the status of a trip. Is there a transportation provider assigned to the member's ride? Is the vehicle on the way? Is the member anticipated to arrive on time? That information, there are a lot of, I would say, interested parties in having that information and having it in real time. So it's critical that we are connected to our service delivery ecosystem so that that data can be shared with everybody that needs to see it. Additionally, you might have a member that cancels, maybe they're not feeling well or they have a personal obligation and they need to cancel their medical appointment. Or you have a facility that closes due to inclement weather or a holiday. Those changes in status and those events are critical to communicate to everybody as quickly as possible. So our platform is really designed to provide that sort of immediate and appropriate awareness to all stakeholders the second it becomes available. And that requires a heavy investment in technology and integration. Not to go on too long, but in terms of interfacing with other systems within the healthcare industry, getting integrated with EHRs, electronic health records, and medical records is critical. It helps us do a variety of things in terms of continuity of care, but also preventing fraud, waste, and abuse.
Yeah, and kind of picking up with that integration piece, given that you're working with so many different segments of the industry, have you found that it's, some are easier to integrate with and others maybe aren't quite there? Or kind of what has that overall experience been like, since integration does seem to be a friction point, despite it feeling like the technology is there and available and ready to make it easy?
Yes, integrating with our partners is both an important opportunity for us and also requires a lot of creativity and development. Different healthcare providers and different members have different levels of technology access, technology savvy, and work across a number of systems. For instance, you could look at all of the different electronic healthcare systems ranging from Epic or Cerner, and how do we integrate with all of those? The first thing that we do is we build native tools that are designed for all of our users and all of the use cases that make it easy for people to log into one system, one portal, and manage all of their needs there. But for people that, let's say, clinicians or healthcare providers that are working in clinical workflows, we develop APIs that allow us to integrate into all of those different EHRs so that they can work in the system that they're comfortable with, that they have licensed, and manage that directly. That could be scheduling within the EHR itself or a single sign-on that allows them to move from the EHR system into our native tools and easily manage those interactions and transactions with our organization. So yes, there's a great deal of responsibility that we have in order to make sure that we're reaching everyone everywhere with the technology that they need.
Yeah, and that certainly makes sense, because you said it's, you have to try and work with the existing workflows and make sure that, you're not causing disruption, because if that happens, then folks are, probably unlikely to want to interact with the system or, find frustration with it. And for those of you just joining, I'm talking with Ed Hoffman from Modivcare. We've been talking a lot about NEMT and what that is, and then how you are coordinating so many different parts of the industry. And, Ed, kind of building off of some of what we've been talking about, is NEMT utilized to its fullest capacity, or are there areas where you think improvement could be driven?
Some fundamental statistics are approximately 3 to 4 million and possibly more Medicaid members, and approximately 5% of Medicare members have accessed their non-emergency medical transportation benefit through us or through other providers. So there is meaningful utilization. And as you begin to get into the treatment types that are most prevalent, such as dialysis, you actually see quite a bit of utilization and quite a bit of awareness around the benefit itself. However, there are studies that show that Medicaid beneficiaries that are eligible for the benefit a little less than 1 in 3, approximately 29%, are aware that the benefit exists. And of that population that's aware, about 37% have used it personally or for somebody in their life, such as a dependent.
Yeah, so kind of based off of those numbers, as you said, it sounds like a good chunk are aware, but it seems like it might, if I was hearing the numbers correctly, kind of focused on certain populations, and it might be that the full scope of people who are could take advantage of it or use it to improve their access to care. That knowledge could certainly be improved.
Of course, and that's where we partner with our payer partners, the health plans, the state Medicaid agencies. So for people that have routine care or regular and recurring care needs, such as we mentioned, addiction therapy or dialysis or mental health services, there tends to be a lot of awareness and comfort and familiarity with the benefit due to the regularity of the need. Where there's always opportunity to improve is for people that don't regularly have the need, but suddenly find themselves needing it, such as a physician appointment or perhaps physical therapy that for a period of time requires them to depend on the benefit, but they haven't been used to using it before. And so partnering very close with health plans that we serve and state Medicaid agencies that we serve, making sure that the information's readily available, clear, prominent, the instructions on how to leverage it and what's required are very clear to all the members is critical in making sure that people make full use of what they're eligible for.
Yeah, and I feel like this is probably more of the explaining the type of service type question, and has been coming through in a number of the areas you've been talking about. But does all insurance cover NEMT, or is it only certain types? And for the coverage, is there does an individual need to think about certain things to ensure that the NEMT will be covered?
So for Medicaid beneficiaries, it is universal. It is federally mandated and cannot be altered without specific legislation. Conceivably, changes in Medicaid funding could reduce or impact the amount of eligibility. But for Medicaid members, it is a universal benefit. Now, this can be delivered in a variety of ways. Every state has their own individual approach. Some manage it directly through the state Medicaid agencies, and others work through managed care organizations to deliver the benefit to the member that includes the transportation benefit we're discussing today. There is also availability through certain Medicare Advantage products. It's not required, it's not federally mandated, but many plans have seen the benefit in terms of outcome, access to care, and the total cost of care for members being improved through the availability of the benefit. So they have voluntarily chosen to make it part of the plan types that they're marketing.
That's very interesting about the Medicare Advantage side, where you said that where it's covered, that the plans have seen total cost of care, positively impacted. So is that because people are effectively utilizing and accessing care? Are you aware of what the evidence is that has that outcome?
So that's what requires us to work so closely with the health plans, because we have a view of what we're delivering in terms of utilization of the benefit, the treatment types that members are generally leveraging the benefit for. But in partnership with the health plans, they give us a better longitudinal and global view of the total cost of care. And that's why you've seen it grow so much over the years. It didn't used to be covered. It's only been in the last 20 years or so that it's rolled out in Medicare, but its growth is evidence of the value that it's created for those populations.
Yeah, no, as you're saying, if it's, the scope of coverage is about 20 years old, that is, especially in healthcare, a fairly rapid expansion. And, I think kind of, as you're also saying, you wouldn't necessarily see that rapid expansion if returns weren't being seen, because there is oftentimes so much attention focused on, trying to minimize or reduce what might be perceived as wasteful spending.
Of course. And with continued interest and new models of value-based care, we think that the services that we provide and the access to care that we enable for these populations will continue to demonstrate their value. So as healthcare providers take on more financial risk, such as ACOs, they will be in the best position to partner with us and understand exactly and quantify and validate exactly how increasing access to care in these services impacts the total cost of care as well as the outcomes for the members.
Yeah, and again, I think that certainly makes a lot of sense. And kind of are there any changes that you've seen already where a value-based model has been implemented, or are you involved in helping to shape what the value model looks like to maybe incentivize greater use of NEMT?
That's the trend that we really see emerging right now versus the original model was largely transactional, meaning we were a service provider that was delivering a very narrow part of the overall care experience to the member, which is obviously the ride. If you can't get to your healthcare appointment, it's impossible for you to get the care that you need. However, as reimbursement models and funding models have changed, and there is more focus on the total cost of care, it has brought us and our health plans together even more closely in terms of sharing data and collaborating, doing analysis, and putting us as a company, Modivcare, much more in the role of providing consulting services or providing the necessary analysis around benefit plan design that allows them to very thoughtfully and effectively apply this benefit to impact the cost curve as well as outcomes.
And as you've been involved in those discussions and developments, are there kind of particular setups or particular methods that you've discovered are more effective than others?
So I would say the number one thing sort of calls back to an earlier part of our discussion, which is integrating with EHRs and clinical workflows. So making sure that we are part of the longitudinal tracking of that member's health and spend over time. So making sure that we aren't in a silo outside of the total analysis, but making sure that we are plugged into that. That gives them the necessary data and the necessary connections to really understand the impact of the services we're providing.
Yeah, no, and as you said, if you can be part of that, more wholesome and complete data set and part of that ongoing viewpoint, then I think, as you're saying, that shows that you're fully integrated into what is the full scope of care delivery to each individual, as opposed to being viewed as potentially something that is just ancillary or not central to the ability to interact with a particular patient.
Of course, and we only see that trend growing in the future with the focus on healthcare costs, as well as changes and views on funding. Our ability to be part of that total cost of care and that total health management model for members is only going to grow over time.
And kind of picking up on where you see that growing over time, kind of what do you see as kind of coming down the road when it comes to NEMT and just that integration of services altogether?
Well, there are requirements around interoperability and integration with EHR coming out in the new federal legislation. The One Big Beautiful Bill Act actually carries requirements around interoperability and integration with electronic health record systems, so meeting certain FHIR standards that allow us to plug in and share data in a normalized, standardized way is actually a requirement that's coming down. So this is sort of setting the foundation for more coordinated care and enabling more value-based care models, and then also having that data be portable. So as members move, let's say, from one plan to another, you don't lose all of that history. All of that history follows the member as they go through their healthcare journey, regardless of what healthcare plan they're using what health plan they are currently on and where they ultimately wind up.
Yeah, no, and I think having that spur in the background will, hopefully make a positive change. But Ed, believe it or not, we're already almost out of time. So I'm going to close with one final question, which is, with kind of all those developments and, expected changes that you're just talking about, is there anything in particular that you think is going to happen, over the next year, so in the immediate time frame?
So I do believe that the most recent legislation will produce new dynamics in the industry. With changes in Medicaid funding and increasing the cadence and requirements around eligibility in Medicaid, seeing how that impacts the Medicaid community and being ready to adjust and move support that goes along with members as they move off of one type of coverage to another type of coverage. I would say that that's probably the largest near-term dynamic that we're tracking and preparing for and developing our systems to accommodate, is making sure that as funding changes and members perhaps move from a Medicaid plan to a Medicare plan, we are there and we are integrated and we're able to support them through that journey.
Yeah, no, I think a lot to track. And, I think as you're saying, it's, all going in the direction of, more comprehensive, coordinated, integrated care. So, hopefully, a good picture to be painting for us to follow. But as I said, believe it or not, we're already out of time. I want to thank my guest, Ed Hoffman, for a great conversation today.
Thanks very much, Matt. It was great to be with you.
And thank you to everyone listening. Keep the dialogue going and connect with me at #HCDEJURE. I'm Matt Fisher. Until next time.